Sir, can I start again?
Okay, Dr. Amaka, you can start.
Okay. Good evening once again. I apologize for the uh mix-up with my slides. My outline is as follows: the introduction, statements of surgical importance, relevant anatomy. We'll look at the common anorectal conditions, and then I would conclude. As a way of introduction, benign anorectal diseases are commonly encountered in our clinical practice, and they pose a significant impact on patients' life. Thus, thorough evaluation of these patients, which include history, adequate history, physical examination, notably our digital rectal examination, are necessary to identify these conditions and to exclude malignancy. As a statement of surgical importance, the management of benign anorectal disorders pose challenges to the surgeons, as the patients are often in distress and complications of intervention can commonly be associated with incontinence. Relevant anatomy of the anal canal. It's a 4 cm long canal that is directed downwards and backwards between the anorectal ring and the anal orifice. The relations include posteriorly, it is related to the coccyx, laterally to the ischiorectal fossa, anteriorly to the perineal body and bulb of the urethra in a male, and the lower part of the vagina in a female. Next slide. The anal canal has two sphincters, notably the internal sphincter and the external sphincter. The internal sphincter is formed by the thickening of the involuntary inner circular smooth muscle, and it surrounds the upper two-thirds of the anal canal. The external sphincter is formed by the outer longitudinal voluntary muscle. It surrounds the lower two-thirds, notably not lower two-thirds, not lower one-third, as it overlaps part of the internal sphincter to blend superiorly with the puborectalis muscle of the pelvic floor. The anal mucosa is organized into longitudinal folds known as the anal column, and inferiorly, these columns are joined by anal valves. Above these valves are pouches, which are referred to as anal sinuses, which contain the anal glands and secrete mucus. The anal valves form an irregular circle, collectively known as the dentate line or the pectinate line. This pectinate line is important as it's the junction between the upper and the lower parts of the anal canal, and is also important with regards to its distribution of vascular supply, lymph node, and nerve supply. So above the pectinate line, the anal canal is derived from the hindgut, while below the pectinate line, the anal canal is derived from the proctodeum. The arterial supply above the pectinate line is the superior rectal artery, while below the pectinate line is the inferior rectal artery. With regards to venous drainage, above the pectinate line, the superior rectal vein drains and it empties into the inferior mesenteric vein, while below the pectinate line, it is drained by the inferior rectal vein, which empties into the internal pudendal vein. Lymphatic drainage above the pectinate line is by the internal iliac lymph nodes, while that which below the pectinate line is by the superficial inguinal lymph node. With regards to nervous supply, above the pectinate line, it's a visceral innervation via the inferior hypogastric nerve, while below the pectinate line is somatic innervation via the inferior rectal nerve, where it's sensitive to touch, pain, and temperature. Thus, lesions below the pectinate line are notably to be painful, while those above the pectinate line are notably to be painless. So, importantly, are anal cushions. These are composed of blood vessels, smooth muscles, notably the trace muscle, and elastic connective tissue in the submucosa of the anal canal, and they're located in the upper part of the anal canal. And they're important with regards to knowledge of the benign anorectal diseases. So these are diagrams summarizing the explanation for the anatomy of the anorectal anatomy, bearing in mind from the anal canal, the sphincters, the continuity with the puborectalis muscle, the anal columns, the anal valves, and the crypts, as well as the glands. Here's another diagram. Okay. All right. So this image shows Okay, this is another diagram also showing more detailing the anal canal from the anorectal ring down to the anal verge, looking at the surgical anal canal and then the anatomical anal canal. So this also explains in detail the blood supply to the rectum. So above the pectinate line, blood supply is via the superior rectal artery, while below the pectinate line is via the inferior rectal artery. So the first anorectal disorder we'll be looking at are hemorrhoids. These are defined as abnormal swellings or enlargement of the anal vascular cushions. So they are derived from Greek words hema, which means blood, and then rus, which means flowing. So it's the downward sliding of the anal cushions earlier mentioned abnormally due to straining or to other causes. Anal cushions themselves contribute 15 to 20% of the normal resting pressure. And anal cushions are also important in maintaining continence. So this is a diagram showing in anal cushions. They're composed of blood vessels, smooth muscles, and elastic tissue in the submucosa. So when there's a downward sliding of these anal cushions, that's what we see as the internal hemorrhoids. And like I said, they are located in the upper part of the canal from the dentate line towards the anorectal ring. So the prevalence of hemorrhoids varies and is estimated at 4.4% worldwide. It is commoner in the western region with a prevalence of about 2.8 to 7.5% in England, and in Africa it comes with a prevalence of 0.7%. Peak incidence occurs within the ages of 45 to 65 years with a subsequent decline after the age of 65. So pathogenesis of hemorrhoids, first is increase in venous pressure. If for whatever reason there is an increase in venous compression of the veins, there's congestion, and then there's a poor drainage of the venous plexus or the hemorrhoidal plexus, causing engorgement and causing downward sliding into the anal canal. That's what is manifested as the internal hemorrhoid. If there's a weakness to the fibromuscular stroma, there's also downward sliding of the anal cushions. Whatever causes a downward sliding of the anal, could be it increase in venous pressure or weakness of the fibromuscular stroma, results in downward sliding of the anal cushion, manifesting as internal hemorrhoids. And then conditions that are associated with increased synthetic tone also cause downward sliding of the anal cushions, manifesting as hemorrhoids. So risk factors for hemorrhoids could be pathological or habitual risk factors. Chronic diarrhea, colon malignancies, portal hypertension, rectal injuries, spinal cord injuries are pathological risk factors for hemorrhoids. Habitual risk factors, constipation with straining, low fiber diet causing longer transit time, prolonged sitting in the toilet causing pressure when one sits in the toilet on the pelvic floor, increasing venous pressure, pregnancy, aging, obesity, all that cause increased venous pressure, predisposed to downward sliding of the anal cushions and manifesting as hemorrhoids. So hemorrhoids can be, types of hemorrhoids include primary and secondary. Primary being at the notable places where hemorrhoids occur, which is the 3, 7, and 11 o'clock position, known as the right anterior, right posterior, or the left lateral position. Then secondary hemorrhoids are hemorrhoids that occur at any ectopic site away from the primary hemorrhoids. Hemorrhoids can be classified as external, that is below the pectinate line, internal, that's above the pectinate line, the external being due to the dilation of the hemorrhoidal plexus, the internal being due to the sliding of the anal cushions, and then mixed. So this is a diagram showing the classification of hemorrhoids. Based on degree of prolapse, we have the first degree hemorrhoids where it bleeds but no prolapse. Second degree where there's spontaneous reduction. Third degree when it's manually reduced, and then fourth degree is a permanently prolapsed hemorrhoids. Then with relation to the origin above the dentate line, this diagram shows an external hemorrhoid, the first one that is below the dentate line, the internal hemorrhoid above the dentate line, and then an external hemorrhoid, that's a mixed type occur beginning from the before the dentate line and also involving the external hemorrhoidal plexus of veins. So clinical features, typically the patients present with painless bright red rectal bleeding, commonly after defecation. This is often seen on the tissue paper or covering the pan. Most importantly, the blood is not mixed in, but is seen on the surface of the stool. Patients can also come with chronic mucus discharge and irritation manifesting as pruritus. They feel a feeling or anal protrusion or rectal fullness. They can also present with us with complications, infection, thrombosis or strangulation of the hemorrhoids, or from long-standing bleeding hemorrhoids. They can come in with presentations of anemia. Investigations for hemorrhoids. The investigation to confirm our diagnosis is proctoscopy, where we'll see, especially for internal hemorrhoids, we'll see the dilation of the anal cushions. Colonoscopy is done to exclude any other anorectal pathology that could predispose or could have been causing the hemorrhoids before surgical intervention. Full blood count is done to also full blood count to show us, depending on the presentation of the patient, long-standing anemia, bleeding, anemia, infection, it can also show, and then a clotting profile of the patient, especially to rule out all bleeding and clotting disorders. So these are diagrams showing on the left, there's the internal hemorrhoids viewed through proctoscopy as the dilation of the anal cushions, and then on the right, you can see an external hemorrhoid. So treatment of hemorrhoids. Hemorrhoids are treated first non-operatively through sit baths. The patient is counseled to sit in warm saline, supersaturated saline solution. This helps to first of all shrink the anal cushions, and also secondly, it also helps, it's bactericidal to kill all bacteria. Secondly, patients are counseled on lifestyle modifications, needing high fiber diets, more fluid diet, so that they have shorter transit time. Patients are given stool softeners or laxatives, which such as lactulose or stool softeners, and then anal dilation also done for patients. Although this is controversial, this recent studies have shown that this is controversial and can complicate as incontinence. So minimally invasive procedures that are done for patients with hemorrhoid include rubber band ligation, which is insertion of rubber bands on the hemorrhoids. We have injection sclerotherapy, which is done by injecting 5% phenol in almond oil. This is injected into the hemorrhoids to cause sclerosis, to cause fibrosis of the hemorrhoids. Then we have infrared coagulation, cryotherapy, laser therapy, and then Doppler-guided. Other minimal invasive procedures include the Doppler-guided hemorrhoidal artery ligation. So these are diagrams showing, on my left, there's a diagram showing rubber band ligation. This the rubber band is inserted on the is injected into the hemorrhoids about 1.5 about 0.5 to 1 cm above the dentate line, so it's painless, and then this causes necrosis and then ischemia and subsequent sloughing of the hemorrhoids. On the right is the needle for injection sclerotherapy. 5% phenol in almond oil is injected to cause fibrosis to the hemorrhoidal tissue. So this is a diagram showing laser surgery for hemorrhoids. So another minimally invasive procedure is staple hemorrhoidopexy. Is a circumferential excision of the mucosa and the submucosa 4 cm above the dentate line using the hemorrhoidal stapler. The advantage of this is that it's less painful, there's less blood loss, faster recovery, and then short hospital stay for the patient. Like I said, the submucosa and the mucosa are excised, and then at the same time, the redundant tissue is stapled together. So, but the disadvantage of this, it requires experience in advanced surgical skills, is expensive, and then you could risk injury to the sphincter. Contraindications include fistula in anal, anal fissures, or perianal abscess. So this is the use of this is a diagram showing the stapler used in the stapler used in staple hemorrhoidopexy. So the surgical excision of hemorrhoids is known as hemorrhoidectomy. It is suitable for 3rd and 4th degree hemorrhoids. It can be performed as an open procedure, which is known as the Milligan-Morgan operation, or a closed procedure, which is known as the Hill-Ferguson operation. The complications of hemorrhoidectomy include it could be early or late. Early complications, patients present with pain, acute urine retention, for which we need to categorize patients, reactionary hemorrhage. The late complications include secondary hemorrhage of 7-14 days after procedure, risk anal stricture, and then fissure in anal. So these are diagrams showing the open, and the next diagram also shows the closed hemorrhoidectomy. So the difference is that the open for the open hemorrhoidectomy, after the hemorrhoids are excised, the left open, but then in the closed hemorrhoidectomy, it's sutured. So this shows a total approach for hemorrhoids. Depending on their grading, the grade 1, the grade 2, and grade 3 and grade 4 hemorrhoids. The early grade, we can start with minimally invasive, conservative management towards minimally invasive procedures. Then at grade 3 and grade 4, we can prepare patients for or hemorrhoidectomy. That's the summary of this slide. So the next condition we'll be looking at is the anorectal abscess. It refers to pus collection in the anal or rectal region. An abscess formation is relatively common in the tissues surrounding the anorectal spaces, and it is commonly due to infection of the anal glands. It includes bacteroides. The pathogenesis of abscess and fistula are usually the same. Notably, the abscess is the acute phase, and then the fistula is the chronic sequelae of the abscess. This image just shows a perianal abscess in a Caucasian patient. As a form of epidemiology, abscesses are common in men than in women, and it's commoner in patients who are immunosuppressed or diabetic. 95% of anorectal abscesses are due to cryptoglandular disease. Others include injuries to the anorectum, cutaneous manifestation, blood-borne diseases, chronic disease such as Crohn's disease, tuberculosis, and then post-anorectal surgeries. So when we're looking at the anatomy of the anal canal, importantly are the anal glands. So anorectal abscesses are thought to be caused by plugging of the anal ducts that drain the anal glands. So these anal glands are located primarily in the intersphincteric space. So if there's any blockade of the anal duct, the glands, there's stasis, fluid stasis in the anal glands, causing bacterial proliferation. So this obstruction to these ducts can occur secondary to fecal matter, foreign bodies, or trauma, all resulting in stasis and infection. So the glands spread, the infection pus now spreads into spaces within the anal glands and the spaces within the anal canal. So anorectal abscess, based on the pathology, can be defined. It can be categorized into perianal, ischiorectal, intersphincteric, and then the superelevator. The commonest types are the perianal and the ischiorectal abscesses. So this diagram shows the spread of the anorectal abscess using the cryptoglandular theory. So when there is a blockade in the blockade to the anal ducts that drain the anal glands. There is stasis and then subsequent proliferation and infection and proliferation of bacteria in the anal glands. So the pus spreads into the spaces, notably the intersphincteric space, or it can come down towards the perianal space, or go above towards the supralevator, above the sphincter, going towards the supralevator space. So this diagram shows the spread of the anorectal abscesses into the spaces that are surrounding the anal canal. So as earlier mentioned, the anorectal abscesses could be perianal when there's a vertical downward spread from the intersphincteric space to the anal margin. It could be ischiorectal when it's across the external space from into the ischiorectal fossa. It could be intersphincteric when it is limited between the internal and the internal anal sphincter and the external anal sphincter. It could be supralevator when it extends vertically, and this one manifests as the supralevator access manifests as a vague discomfort, and it's difficult to diagnose in these patients. And a diagnosis is usually achieved by examination under anesthesia. Then, when the abscesses spread circumferentially from one side to the other, it is also known as the horseshoe abscess. So, for abscesses, anorectal abscesses, every abscess should be drained when diagnosed. For the superficial abscesses or simple abscesses can be drained under local anesthesia in patients who are otherwise healthy. Inpatient care is needed for patients with systemic symptoms, patients with immunosuppression, patients with complicated or complex abscesses. So this is a diagram showing abscess drainage in a patient with anorectal abscess. The abscess is drained using a cruciate incision done on the abscess and then drained subsequently. So the chronic sequelae of an anorectal abscess is fistula in ano. So it's an abnormal tract lined by granulation tissue which connects the anal canal or the rectum to the skin around the anus. It is usually from a pre-existing anorectal abscess which was spontaneously closed or was opened inadequately. This fistula continues to discharge and seldom, if ever, closes permanently without surgical intervention. As explained earlier, it could be due to cryptoglandular disease in 90% of cases or non-cryptoglandular disease in 10% of cases. It is commoner in young adult males with a male-female ratio of 2:1. So fistulas can be classified according to their relation, the internal opening, the relation below or above the anorectal ring. If it will be low-level fistula if the opening into the anal canal is below the anorectal ring, or high-level fistula if the opening into the anal canal is above the anorectal ring. Other classifications include the Milligan-Morgan or the standard classification, and then the Pax classification. So the next diagram shows the classification according to Milligan-Morgan. It's classified into 5, starting with the subcutaneous, the low anal, the submucous, the high anal, and the pelvirectal. So the pelvirectal is above the anorectal ring. However, from the subcutaneous, submucous, high anal, and low anal types are below the anorectal ring and are low fistulas, low-level fistulas. So Park's classification is according to the opening, the connection between the space and the skin opening. So it could be intersphincteric, that is when the fistula opens directly between the sphincters to the skin. It could be transsphincteric when it goes from the anal canal towards the through the internal sphincter to the external sphincter and opens to the skin. It could be supralevator or suprasphincteric when it's above the sphincters. And then it could be extrasphincteric when it's way above the sphincters and not related to the internal or external sphincters. So as earlier mentioned in anorectal abscess, we see sphincters that, we see fistulas that were connected to, were in this previous abscesses that were in these spaces, manifesting as fistulas in the chronic states. So principal symptoms of this patient is a persistent cerebral discharge that irritates the perianal skin and causes discomfort. The history is actually chronic, dating back to a few months to years. Pain is a feature if the orifice is occluded and increases until the fistula ruptures and starts discharging. Frequently, we see a solitary external opening, usually located within 3.5 to 4 cm of the anus, and it presents as a small elevation with granulation tissue pouting from the mouth of the opening when we examine a patient. Then superficial healing may occur with accumulation of pus and abscess formation, and then it could discharge through the same opening or a new opening. So patients will keep giving you giving us a history of a discharge that they notice that heals up and then reopens again. So it dates back for a longer period of time as opposed to an anorectal abscess. So as a rule, there is much induration on the skin and subcutaneous tissue around a fistula because of the chronic inflammation. So these are diagrams showing anal fistula. So importantly in the management of anal fistula is the Salmon-Gussal's rule, which states that external opening posterior to the transverse, using the transverse anal line. There's a diagram in the next slide that will also explain fully the Salmon-Gussal's rule. But using the transverse anal line, fistulous tracts that are posterior to transverse anal line follow a curved course to the posterior midline, and then fistulous tracts, external opening anterior to transverse anal line. The fistulous tract will follow a straight line to the dentate line. Exceptions to these rules are anterior anal openings that are greater than 3 cm, which may follow which may curve posteriorly and end in the posterior midline. Next. So this diagram shows the explanation of the Salmon-Gussal's rule. Using a transverse anal line, fistulous tracts that the external openings that are anterior to the transverse anal line, the fistulous tract follows a straight course to the midline. Transverse canal, any opening behind the transverse anal line, the fistulous tract follows a curved opening. Then exceptions to this rule are long anterior fistulas greater than anterior openings that are greater than 3 cm. They follow a long curved tract to the posterior midline. So investigations in patients presenting with fistula in ano, importantly is fistulography. This shows this outlines the tract of the anal fistula. This is the initial investigation done for patients with fistula in ano. It shows, it outlines the fistula, the fistulous tract in this patient. However, the limitation for fistulography does not show the relation to the anorectal ring. So we still need to further investigate the patient to be able to know its relation that would inform our management of such patients. So the most definitive, which would outline the relation of the anal fistula to the sphincter, is the MRI. It will outline the tracts of the the fistulous tract as well as the relation to the sphincter, which will be able to tell us if it's a low-level fistula or a high-level fistula, and it will also inform our management of this patient, as earlier mentioned. So in treatment, the objective of fistula surgery is to cure the fistula with the lowest possible recurrence rate. And if there's any alteration, be it minimal, to do so in the shortest period of time. Principles of surgery is that the primary opening of the tract must be identified. We need to be able to outline the tract completely from the skin down to this opening into the midline. The relation between the tract and the puborectalis muscle must be established. That way we will know if it's a high-level fistula or a low-level fistula. Then division of a least amount of muscle is done in keeping with the fistula repair, so that we don't risk incontinence. Then side tracts, as earlier mentioned, the fistula's opening could open to different places. So side tracts must be sought out. And then we need to know if it's the presence or absence of an underlying disease. We need to determine it while we're managing a patient with fistula in ano. So bearing in mind these principles of fistula repair, For low-level fistulas, the treatment options include fistulotomy, which involves laying open of the fistula and allowing healing by granulation for tissue formation. Another method of repair is the fistulectomy, wherein the fistulous tract is completely excised, and then there's primary closure of the perineal wound under appropriate antibiotic cover. This is done in wounds that, in situations where the fistulous tract wouldn't be related, there's little infection with the fistula, and then there's no risk of breakdown of our repair. There's also called the PAX operation, wherein we drain, internal sphincterectomy is done to drain the intersphincteric region, and then it's laying open the fistula external, lateral to the external sphincter. So for high-level fistulas, if they're secondary to a primary condition, we need to, as part of our principle, we need to treat the underlying condition, and then a proximal colostomy might be required in such patients to be able to protect our distal repair. Secondly is the use of the seton technique. A seton is a non-absorbable suture. It could be silk, it could be linen, it could be monofilament nylon that is passed across the fistula and left in place with a tie. A striated muscle superficial to the fistulous tract is encircled with the seton material and is tied securely and left in situ to create ischemic necrosis, dividing the muscle slowly without allowing it to spring apart. So the fistulous tract is laid open and then allowed to granulate. And seton can be kept for 2 to 3 months. Setons can either be loose. Okay, this is a diagram. Sorry, sir, let me cover. This is a diagram showing the use of seton in management of a patient with a fistula in ano, in a high-level fistula in ano. So this diagram shows the use of the loose seton, although the seton can be a tight or cutting seton, but in this diagram is the use of the loose seton. So it's kept there, and drainage is it's kept there for drainage of the of the fistulous tract, after which the seton is removed, and then we'll plan towards a fistulotomy for this patient. So, as earlier mentioned, types of seton could be loose seton, in which is loosely tied for drainage, and then it could be a cutting seton, in which is placed tightly, and patient comes in periodically for it to be cut and then firmly attached. Then for complex fistulas, there could be injection of fibrin glue or insertion of a porcine small intestinal submucosal plug. Then we could use the use of surgices or a sliding flap advancement for complex fistula. So the final benign anorectal condition we'll be looking at is the fissure in ano, which is a painful linear ulcer situated in the anal canal, and it extends just below the dentate line to the margin of the anus. Extending below the dentate, from the dentate line indicates somatic innervation, and thus anal fissures are painful. It's a common condition that causes suffering out of proportion to the size of the lesion. In the acute phase, the lesion is a mere crack in the epithelial surface, but may cause much pain and spasm. It occurs commonly in the midline, commonly posteriorly because of the poor precarious blood supply in the posterior anal canal. It's commoner in males, but it can occur anteriorly in the midline, and it's commoner in females, usually due to difficult deliveries. So again, 95% of anal fissures in men are posterior, with 5% being anterior. Then 80% of anal fissures in females are anterior, while 20% are posterior, while 20% are anterior. So this is a diagram showing a fissure in ano. So it shows in the acute phase, it's a mere crack in the epithelial surface of the anal canal, and because it is below the dentate line, is associated with a lot of pain and spasm. So is usually posteriorly because of the precarious blood supply of the posterior anal canal. So it can be classified based on duration, acutely if it is less than 6 weeks, and then chronically if it is more than 6 weeks. It can also be classified based on presence or absence of underlying disease. Primary fissures are fissures in which there are no underlying disease, while secondary fissures are fissures due to an underlying disease, such as an inflammatory bowel disease. For anal fissures, they're usually caused by inflammation or trauma to the anal canal. Risk factors include constipation, dehydration, inflammatory bowel disease, chronic diarrhea, and previous anal surgeries. Constipation with the straining of passing stool, there's a longer transit time. There's more absorption of water from the stool. The stool is harder. With straining, there's a tear to usually the posterior anal canal, and then leading to anal fissure in such patients. So clinical features based on the etiology, the patients come in with pain in the anus during and after defecation. So bleeding is very common. Then in the chronic state, there is the presence of a large sentinel pile. Patients can complain of a discharge, especially through especially if infected. Then patients are constipated because they are afraid to pass stool. So it's a vicious circle. The patient develops constipation due to usually maybe due to diet. Then there's passage of stool with straining, leading to an anal fissure. And then because of the pain during defecation, there's a subsequent a fear to pass stool, and then there's more hardness of the stool, and patient begins to get afraid of passing stool, and then there's more risk of, and then so it's a vicious circle, constipation resulting in more and more pain for the patient with anal fissure. So oftentimes the patient will refuse a digital rectal examination due to intense pain, and then examination under anesthesia may be necessary to make diagnosis. So fissures within the canal when examined under anesthesia can then be identified under proctoscopy. So acute fissures, as a form of talking about the pathology, acute fissures usually heal spontaneously with conservative management, but in situations where there's a considerable reluctance to heal, secondary changes occur as a result of failure to healing. And these changes include the sentinel pile, there's hypertrophy of the anal papillae, and then there's fibrosis of the lateral edges. There's the ulcer base is also fibrosed, and there's suppuration or abscess formation. So as I explained earlier, persistently hard bowel movements perpetuate the condition, so resulting in an abnormality of the internal anal sphincter, which maintains continence. So there's increased resting pressure in the anal sphincter, there's contraction of the sphincter, and then the sphincter, as it's contracted, still causes ischemia to the ulcer. So it causing ischemia to the ulcer. So there is poor blood supply, then the ulcer doesn't heal on time, and then chronic anal fissures persist. So posterior commissure, like I explained earlier, are less perfused than the anterior portion of the anal canal, which explains why the posterior commissure is more affected by anal fissures than the anterior canal. So treatment of fissures, in acute fissures, is to avoid constipation, which includes increasing fluid and fiber intake, and then use of stool softeners, and then commencement of seat baths. Then can do a pharmacological or chemical sphincterotomy, which includes the use of nitric oxide donors such as glyceryl trinitrate, the use of calcium channel blockers such as diazepam and nifedipine, and then use of botulinum toxin, which blocks the action of acetylcholine on the postsynaptic membrane, and then the use of muscarinic agonists such as beta-nicole cream. This all all these cause smooth muscle relaxation, and so to increase blood flow to the fissure and promote healing and symptomatic relief in such patients. So for chronic fissure in ano, do a fissurectomy, which is a classic excision. It could we could do a V2Y anoplasty, which is an advancement flap technique. Anal sphincter dilatation is also done, and then lateral anal sphincterotomy is a surgical procedure also done for patients with chronic anal fissure. So in conclusion, benign anorectal conditions are common presentations which are often distressing to the patient. Prompt diagnosis and management, including patient education, provides relief of symptoms and improve quality of care. Thank you. Thank you. These are my references. Thank you.
Thank you very much, Dr. Chiamaka Amadi, for the presentation on benign anorectal condition. As mentioned earlier, benign anorectal condition is a common condition that we see in general surgery outpatient departments. The condition usually is embarrassing to a patient, to most of the patients. And of course, they can present as an emergency. Some of them present in an emergency situation, any type of these fissures, being it hemorrhoid, you can see them with severe anemia presenting as an emergency from profuse bleeding, or they can present as a thrombosed hemorrhoid with severe pain. And all others, the abscess present as an emergency, the fissure, they can present with severe anal pain. So it's a fairly common condition we see in our clinic. You hardly run a general surgery clinic without seeing this condition. So we'll now open the floor for comments and contributions. If you have a comment, you indicate by putting up your hands, then we allow you to talk. After all our comments and our contributions, we'll now hand the floor to Professor Yawe, our mentor and teacher, to make the final comments before we close for the day. Thank you all. So if you have a comment, questions, you can indicate, please. Any questions, comment? Yes, I can see Dr. Garzali, Umar, a consultant, general and hepatobiliary surgeon from Anatomical Teaching Hospital. Good evening, sir, and you are welcome. The floor is yours.
Thank you very much, Dr. Bashir. Good evening, all. Good evening, Prof. Glad to have you with us. Yes, Dr. Amaka, thank you very much for the presentation. It's a very good attempt to make some effort. Benign anorectal condition presentation in 30 minutes is a very difficult task, so I appreciate your effort. Well done. Now, in your synopsis, you mentioned that you wanted to briefly highlight some common causes of benign anorectal condition. Maybe this was the old slides. You didn't put it there, but it will have made sense. Yeah, look at it there. Common anorectal conditions. But I didn't see the slide. Maybe this is the old slide. That's why you didn't bring it here. So it's something to just have in your PowerPoint, so that you mention the common ones and just mention few like the pruritus ani, proctasia fuga, rectal prolapse, among other things. It's very important. Thank you. Then when you were discussing hemorrhoid, you mentioned investigation as a proctoscopy as the investigation of choice. I just want to highlight something. Ideally, proctoscopy is a bedside examination. It's an extension of detailed rectal examination. It's not really an investigation per se. Proctoscope is something we should have in our clinics. Once you finish and you want to look, you can just pick your proctoscope and look at it. Yeah, so I think it's it's an extension of the rectal examination, proctoscopy. Then when you were discussing stapled hemorrhoidopexy, one important complication you should take note when you are performing stapled hemorrhoidopexy is the urethral injury, especially when you are taking the anterior knots. If you have, anterior bites, if you have assisted staple hemorrhoidopexy, you have to take a posturing bite throughout the rectal mucosa, anal mucosa before you shoot your gun. So if you are not careful anteriorly, if you take a deep bite, you can actually pick the ureter and injure it, and patient will present with hematuria post-operatively. That's very important. Then, while you were discussing complication of hemorrhoidectomy, you mentioned acute retention, and the first thing you mentioned was for which we catheterize. You should know that a patient that had hemorrhoidectomy and developed acute retention, catheterization is not our first line of action. There are steps you follow. Ensure it has adequate analgesia, change of position, then psychosomatic inhibition by opening a nearby tap may succeed in ensuring this patient actually pass urine. If all fails, that's when you now consider catheterization. Then when you were discussing abscess, you did justice to the topic there. You mentioned horseshoe-shaped abscess. You should know that this is only seen in patients that have bilateral ischiorectal abscess. Patient that has subcutaneous abscess may not have horseshoe shape, but if he has ischiorectal communicating behind the anal canal, that's when it manifests as horseshoe-shaped abscess. Then abscess, patient with anorectal abscess, you should know even the best surgically drained abscess, up to 50% of them come down with perianal fistula. So seeing fistula after draining abscess does not mean your surgical technique is faulty. It means that the fistula rate is just so high, up to 50%. Then one of the classifications, if you mention complex abscess, though I think you mentioned it in passing, complex abscess when you have multiple openings, or abscess occurring in anal Crohn's disease, tuberculosis, and lymphogranuloma venorum. Then your exception to Salmon-Good-Source law, you should know that this complex abscess do not follow Salmon-Good-Source law. If a patient has abscess from tuberculosis, it does not follow the Salmon-Good-Source rule that you highlighted. Very good attempt once again. Then in patient with fissure in ano, yes, they usually don't allow you to put your finger. But if you are to pat this patient buttocks, you may be able to see the fissure at the posterior midline. It may be painful, but you may actually be able to see it before you do your examination under anesthesia. Once again, thank you very much, Dr. Amadi. It will be a very good attempt. Keep it up. Thank you very much, Dr. Bashir. And thank you, Prof, for being with us.
Thank you, sir.
Thank you very much. Yes, any other comment? You can indicate, please. Dr. Peter Eze, a senior registrar in general surgery. You have moved to Gwagwalada with for your outside posting. Hope you'll be meeting Prof. Prof is with you now.
That is good. Thank you, sir. Good evening, sir. Good evening, Prof. Thank you for allowing me this opportunity. Thank you, Dr. Amadi, for the wonderful presentation. I was just wondering, the 4 conditions you presented: hemorrhoid, abscess, fistula, and fissures, but that may not be all the benign conditions that are seen in the anus. Maybe you would have also, you might also mention abscess. You would have also talked about prolapse. I don't know whether that, if we're looking at exam conditions, whether we should include that. I think we should be able to include that, prolapse, and perianal hematoma, which can also present as a hemorrhoid. There are other benign tumors. There are also benign conditions which we may also mention. Can also discuss warts, which can also present in the perianal area. So those are other conditions. You may not discuss them in details, but you can also mention them in the passing. There are also benign conditions that could occur in the anus. Trauma in the anorectal area can also present. And in some of these conditions, you remember that colostomy, diversion of these two, can be a way of treatment to help with healing, because what actually causes perpetuation of these conditions, fistula, fissures is the special condition of that area, and also the increased bacterial load, which with diversion, you'll be able to reduce that and allow for healing. Thank you so much once more for your wonderful presentation.
Thank you very much, Dr. Eze, for your contribution. Any other questions, comments? Dr. Deshi.
Thank you so much for the opportunity, sir. All protocol duly observed. My question is on hemorrhoids. I think among all the conditions, the most common is hemorrhoids. So of the hemorrhoidectomies now, which one do we commonly do? Is it the open Milligan-Morgan, or is it the Ferguson, or the intermediate between the two? That's the Pax operation and also Franz-Arnold. So which one, what will inform the type of hemorrhoidectomy you will do for a patient? That is one question. My question. Then in fissure in ano, the chemical sphincterotomy, what is the failure rate, and is it a common practice that you should always go for them, bearing in mind the cost and then the failure rate? Thank you.
Amaka, you can attempt those questions. Amaka, did you get the questions?
Sorry, my mic was muted. I've muted myself. Thank you, Dr. Deshi, for your question. But the question with regards to the which of the hemorrhoidectomy techniques are commonly practiced between open and closed. Did I get your question, Dr. Deshi?
Yes.
Yes, sir. Is the open technique that is commonly practiced? That's the Milligan-Morgan's technique, sir. Then, with regards to failure rates with pharmacologic sphincterotomy, they have a failure rate of about 50%. I'm sorry, I didn't get the second part of your question, but they have a high failure rate of about 50%.
Yes, Dr. Amaka, most surgeons prefer to do the Milligan-Morgan technique because they have lower risk of infection, post-operative infection, than closing the Ferguson technique. After excising, you have to close. So the risk of infection is quite lower in Milligan-Morgan. That is the one we commonly do. And all our trainers, we see them commonly do the open type and then the closed type. I don't know if Dr. Garzali or Prof have a comment on this particular issue.
No, I am good. Thank you very much. But I have a comment on the chemical sphincterotomy. Dr. Amadi, you mentioned the failure rate of 50%. That's high. Now, for the calcium channel blockers and the nitroglycerin, yes, failure rate is 50%. But for botulinum toxin, the success rate is up to 85 to 90%. And if you remember, it works by inhibiting the action of the internal anal sphincter for up to 3 months. So in fact, some studies actually report a success rate of up to 90%. And though there's some risk of incontinence to flatus, which is minimal. So based on the question that was asked, I think it's cost effective because we use it Bashiri with us in Kano. We use it routinely in Kano for those that we have failure of diltiazem or nitroglycerin. So for botulinum toxin, the failure rate is around 10 to 15%. And so the success rate is very good compared to maybe the other. So I think if you have access to it, you can use the botulinum toxin. Sorry, it is good. Thank you.
Thank you, sir.
The truth is that this is also Obviously, any procedure that has a failure rate means is limited in what it can offer. Generally, in surgery, you will notice that there are always many procedures, multiple procedures, whether we are doing conservative approach or radical approaches. They are conservative. Why we have multiplicity of procedures. And I think Garzali is quite right. Botulinum toxin is one of the probably the best in this regard of the conservative approaches, non-surgical, non-operative approaches. Maybe Bash, is that okay? I agree with you that open hemorrhoidectomy is what we have commonly practiced. My late boss, Professor Ajao, used to emphasize that safety first. Safety first. There's no point doing something heroic and then having, which you know fully well, there are complications. The bacteria count in this area where we're dealing with is about 10 raised to power 24 per gram of feces. That's very high. So if you are going to attempt something that you know fully well, closure will bring about such a high complication rate, it's probably unwise to do close. But I know of people who have been doing this, especially when they do bowel preparation, they fairly radically reduce the counts and they think that is acceptable. But I haven't, as a practice, I do not use the closed procedure, I use an open procedure. That's my practice, my preference, actually.
Thank you very much, sir.
Yeah, if you have met somebody who has secondary hemorrhage following this procedure, and you have sweated, you will know. In tell you, any skin you slap in there may actually necrose the sepsis. And
Yes,
then the thing we haven't mentioned is a possibility of this eventually leading to systemic infection as a presentation of an anorectal condition generally, but particularly of this procedure. So these are some of the reasons why sometimes it's better to opt for safety, knowing that yes, it's good for the wound to heal primarily, but it may not heal primarily, and therefore it will give you a lot of problems. So on that point, that's what I would say. I don't know if you want me to continue.
Thank you, Prof. Yes, any other questions? Any other question, comment from the resident?
I think Prof can continue. He already has the floor.
Prof advised the residents to read around the topics before presentation. And we have
Yeah.
2 residents that have commented. Okay, we can hand over the presentation to Prof to continue.
Okay. All right. Thank you very much. I think Amaka has, like you and Garzali have said, you understand there are some limitations to this kind of presentation from a resident. Depends on whether they have actually soiled their hands. Some of the procedures, in that way you talk better authoritatively. But I think he has done quite well. He did quite some good reading. I didn't see the literature that she used. I know somehow something came up. I didn't look at it. I always like to see your references so I can advise in this area of dissertation and PhD program for clinical teachers. But I think Bash, you say something very interesting. She presented anorectal conditions like usual day-to-day straightforward matters, There are systemic involvements in systemic presentation of these conditions, dramatic presentations, acute, very acute presentations, which I think something that she missed out. These hemorrhoids can present with actually systemic infection, anorectal abscess can present as systemic infections. So it's good to make sure that you let us know you are at home with the general presentation of conditions of this nature, not just localized features alone. At the point as I made, incidentally, I just completed a chapter. We're writing a book with some people in the Caribbean, and this is a topic that I actually wrote on with another person. It was quite fresh to my mind what we wrote. It's a book for medical students and residents, and I particularly was drawing the attention to some of the tropicalized conditions. She has mentioned a number of very good things, but there are other tropicalized conditions. As I mentioned, one or two of them, cyanosis, tuberculosis and schistosoma involvement, amoebiasis and cutis, and so on. These are a few things that they are not very common, but in the general outlay, you should have mentioned them. But I think pollinator cyanosis is actually common. And the reason why what are becoming common now is because of our lifestyles. And so it will be a wise idea to talk about condylomitis in this presentation. I think that is important. And of course, to go to the lower age group, you should actually talk about pruritus NI as a specific condition. That much I thought she should add. So I think in terms of discussing the management, I think you should always try to look at the conservative approaches and then, or rather the what you call the non-operative and then the operative approaches. And I am happy you took a long time on hemorrhoids. You should try and differentiate, or rather explain, put it very clearly, what are office procedures and non-office procedures. That is from a practical point of view. I mean, just like what Garzali was mentioning to you, anoscopy is not something you call an investigation. Actually, it's part of the examination, and I think it's one of those things I said earlier. If you have seen it over and over, you'll be able to talk about what you do in practice. But all said and done, I think she did fairly well. You need to read a little bit more about hemorrhoids. It's a very topical subject. We have brought this question for even part 2 in general surgery before, so don't think it's something that is too small. No, it's not. I wasn't really at ease with your classification of hemorrhoids. She used very many classifications in a discussion like this to show, not to display the knowledge base, you know. But I think all said and done, you did well. I wouldn't complain too much. Some of the procedures you're describing depends on whether you have done them yourself. But I think this is what residency training is all about. Whether you're done it by yourself on your list or not, you should try and make sure that when a procedure is being done, you find yourself there and see, just like what Garzali was mentioning about using staples and so on. So let me end my little comment by talking about the complications of hemorrhoidectomy. I think the operation is a very common operation. The condition is a very common condition. We expect you to know everything about the complications of hemorrhoidectomy. I'm sorry to say this, but you cannot be excused if you do not know all. You should know all. It comes up not just in the essay that I mentioned. It's something that we see also in the multiple choice questions. And if I may leak a little bit more information, this is a topic that is being used from various perspectives as a dissertation topic. So it is common. You know, you're not going to look for things from heaven. You look for things you're seeing here on earth. So I think you should go back and spend a few more moments on hemorrhoids, and management of hemorrhoids. Recently, look at the local literature there is quite some local literature on this subject. And if I may advise the residents, this forum is one of the what I call the formative assessment fora that is highly. The more you spend time preparing for it and coming here, the better you'll be. So this is, let's not take this for granted. Therefore, if you are given a topic, please don't just consult Bailey and Love. Our textbook of Bedo, Baja. No. Also look at some of the local publications on the subject. And then you will be able to quote statistics and get a deeper and a better understanding. For example, I would have loved to know from Amaka if she had spent some time, what is the burden of hemorrhoids, hemorrhoidal disease in Nigeria? You can see what has happened in Northeast, Northwest, Southwest, and so on and so forth, and be able to say where the national program is something of this nature. So that's only the addition I'd like to make to it. But I think she has done a fairly good job. And as Garzali said, mention a number of conditions, but then cone down on the ones. And I like the way you cone down on 4. That's good, but list the others as well, so that we know that you actually did a lot of reading on anorectal conditions. Now, the final point is that you said anorectal, but you actually discussed only anal conditions. So bear in mind that prolapse may not be as common a problem in adults as you see in children, but it's coming up. If you go to immunosuppression clinic, you'll find lots of people who have had diarrhea diseases floating, moving around with some level of degree of rectal prolapse as a major challenge to them. So I think it's an evolving problem even for adults as well. And you should not forget to mention the topic anorectal. At least there are some rectal conditions which you could talk about, including amoebiasis and schistosoma infestations of those areas in which they come up with some level of symptomatology that can be distressing, including hematochezia. So, Bash, thank you very much for the opportunity to highlight one or two things and to draw attention of the residents, and indeed all of us in clinical. Thanks.
Thank you very much, Prof, for your guidance, all the comments, all the contributions. Thank you, Amaka, for the presentation. Dr. Garzali, we are really grateful for having you with us today. So we will close the presentation for this week, and subsequently I will upload and announce the presentation early so that the presenter start making his slides and submit to the moderator 2 days before the presentation so that he can make edits. And also the resident, as Prof always advised, you should go back and read in depth these topics before the presentation so that you can make meaningful comments, meaningful contributions, ask questions, because if you ask questions, there will be an opportunity for the seniors to discuss around that questions, and light will be thrown on such areas. So thank you once more, everybody, and Happy New Year. We are going to close the presentation for today. Thank you, Prof.
Thank you very much.
Thank you,
Thank you, sir.
Dr. Have the nice rest of the week. Thank you very much.
Thank you, sir.